Good morning. Welcome to the YWCA's Talk on Health. This is a monthly conversation with healthcare professionals where we discuss things where we try to reach out to the community, to people who don't normally have access to healthcare professionals. It is a collaboration with the Wilmington chapter of the Delta Sigma Theta Incorporated alumni chapter, as well as the Lower Cape Fear YWCA. We always begin with the land acknowledgement from the YWCA. The YWCA of Lower Cape Fear serves the people located within the Lower Cape Fear region. This land once thrived with life from indigenous peoples, known today as the Cape Fear Indians and the Waccamaw Siouan Indian people, living in established settlements along the Cape Fear River and Lake Waccamaw, along with many other established sites in the region. We need to protect and honor the history of these places. Indigenous peoples are not relics. They are still here, continuing to demonstrate their talents and gifts amidst the backdrop of ongoing colonialism and oppression. They are worth celebrating. We hope that our land acknowledgement statement will inspire others to stand with us in solidarity with Native nations. Thank you very much. I'm very excited today. We're going to talk about gestational diabetes. This is the third in our series. The first part of our series, if you missed it, was on type 1 diabetes. And last month we talked about type 2 diabetes. They were great conversations, and I'm looking forward to another wonderful conversation on gestational diabetes today. I am going to allow our panelists to introduce themselves and talk about why they are here today to talk to us about gestational diabetes and what expertise they have. We will start with Dr. Imelda Odibio. I really butchered your last name and I apologize. You're muted, Imelda.
Sorry about that. Okay, my name is Dr. Odibo. I am an OBGYN and my specialty is in managing high-risk pregnancies. So I am a maternal fetal medicine specialist here at Novant. And I've been here for about 7 years now. So I really specialize in managing patients who have diabetes, high blood pressure, any maternal complications, and also any fetal complications like babies who have congenital anomalies, defects, and things like that. Thank you for having me.
Thank you for spending this hour with us today. Next, we have Hillary Budkowski. Hillary, would you please introduce yourself?
Hey, I'm Hillary. I'm a registered dietitian with Summerfield Custom Wellness, and I'm really excited to talk to you guys about gestational diabetes because we know what a role that our diet can really play in helping manage those blood sugars and helping you have a happy and healthy pregnancy. So excited to explore that side of it with you guys.
All right, thank you very much for joining us today. And next we have Janelle Montgomery.
Hi, my name is Janelle Montgomery. I'm a clinical pharmacist. I currently work at Duke University Hospital. I'm actually in a neurology clinic, but my training was in a family medicine clinic. So we actually get a fair amount of questions in neurology about pregnancy. So I'm happy to kind of share what information I have from my perspective. I'm happy to be here today. Thank you.
Thank you very much. We always have to have pharmacists when we're talking about diabetes. So you guys are invaluable. Thank you for coming today too. Next we have Mandy Boykin McCoy.
Hi, I'm Mandy Boykin McCoy. I am a clinical pharmacist practitioner at UNC Health. I work in a family medicine clinic where I manage chronic disease states like diabetes, hypertension, and hyperlipidemia. So I have a big passion for diabetes, and I'm actually a new mother myself, so had to kind of look up this information during my pregnancy as well.
Awesome. We're lucky today. We have two pharmacists. Thank you guys both for coming. Okay, well, we're just going to jump right in. Imelda, could you please tell us what is gestational diabetes?
So gestational diabetes is diabetes that develops just during pregnancy. This is not type 1 diabetes, and it's not type 2 diabetes, which happens outside of pregnancy. So during pregnancy, there are a lot of hormonal changes. The placenta itself releases a lot of hormones, and there are other physiologic changes that happen during pregnancy, including weight gain, that causes women to develop this form of insulin resistance. So they're not able to utilize the insulin they have very well, and that leads to the development of gestational diabetes. And what happens in some women is that your pancreas, which is the organ in your body that makes this insulin, is able to probably make more insulin in some women and overcome this resistance. Whereas in a certain percentage of women, this doesn't happen, and they end up with a diagnosis. And as the CDC gives us an average of 2 to 10% of pregnancies that are complicated by gestational diabetes in the US.
Thank you very much. I'm going to follow up, piggyback on something that you said and ask you, is there ever a time that there's insulin resistance associated with gestational diabetes? Is it almost always just not having enough insulin?
Sorry, I didn't quite understand your
Oh,
question.
I was saying, is there ever insulin resistance? Like the body is just not using the insulin properly, or is it almost always just not having enough insulin?
The body is not
Gestational diabetes. Okay.
The body is not using the insulin properly, yes, because of some of these hormones that are released by the placenta during pregnancy, and also the increase in weight that most women experience during pregnancy.
Okay. And I'm going to ask Hillary a question next, which is there a way pregnant women should be eating that can decrease their possibility of getting gestational diabetes?
Yeah, so when we think about food, the first and foremost important thing to think about is what breaks down into sugar to raise our body's blood sugar levels. So we know that anything with carbohydrates break down into sugar. So that's fruits, that's rice and grains, beans, legumes, breads, sweets, desserts. All of those foods break down into sugar and can raise our body's blood sugar level. Now, that doesn't mean we cut out these foods to prevent the risk of gestational diabetes, but the importance of balancing those carbohydrates so that our blood sugar levels stay within normal limits. So having a balanced plate of protein, because that's going to be a buffer for your blood sugar levels, fiber, and healthy fats. Those are the three big components to nutrition that help to buffer that raise in your blood sugar level. So creating a balanced plate with like half a plate of vegetables, about a palmful size of protein, and then that starch, anything with a carbohydrate in it, about a fistful size of that carbohydrate, and making sure that there's some type of fat source, whether the veggies were cooked with a fat, or you had a little dressing on the side, or the starch had a little bit of fat source, or avocado on top, or nuts or seeds. That's going to really help to keep those blood sugar levels within normal limits, along with being mindful of added sugars like the sweets and desserts and how often those are going to be in the diet.
Thank you. Dr. Odebo mentioned the weight gain during pregnancy. Can either one of you speak to the amount of weight that you should gain in pregnancy? Because when I was pregnant with my 3 children, I was told that I was eating for 2 and I could eat as much as I wanted to eat. And I think that's a common misconception. So could either one of you speak about how much weight you should gain during pregnancy?
Yes, absolutely. So the recommended weight gain in pregnancy is actually recommended by the NIH, and it is based on your current BMI, body mass index. So if you are already in the overweight, in the obese category where your BMI is 30 or more, you are actually required, or it is recommended that you gain only 11 to 20 pounds during the pregnancy. For women who are underweight, which is BMI less than 17, they can gain a little bit more weight. So those women are able to gain probably upwards of 45 pounds during the pregnancy. But women that we worry about are those in the overweight or in the obese category, and the weight gain is really in the obese category, it's 11 to 20 pounds. So yes, we do hear that you're eating for two, but no, not really. We need to basically watch our intake during pregnancy.
Thank you very much.
Yeah.
Can you get rid of gestational diabetes while you're pregnant?
Hillary, you can jump in also, or anybody, but I don't know if I can say get rid of it. You can control it during pregnancy. Technically, it doesn't go away until you actually have the baby, until you deliver and your placenta delivers and your body has all of these weeks, which we suspect about 4 to 6 weeks for things to kind of get back to your pre-pregnancy levels. So I wouldn't say we get rid of it during pregnancy, but I would say some patients are able to be well controlled during pregnancy with either diet and exercise only or with medications. And those medications can be either pills, and we have 2 pharmacists here today, or insulin.
Well, it sounds like almost every pregnant woman is at risk of gestational diabetes. So how do I know if I have gestational diabetes? What are the warning signs? Is there any testing that we do? Yeah. That type of thing.
And I think this is most appropriate for me. So unlike the general population, where when they develop type 2 diabetes or things like that, they have very clear signs and symptoms. There's excessive hunger, there's increased thirst, there's fatigue, there's sugar in their urine. Some people may have frequent urination. Some people may develop yeast infection. In pregnancy, actually, most women are asymptomatic. I do have a few patients here and there who tell me, oh, I'm drinking a little bit more. Increased urination is quite common in pregnancy, so it doesn't really help us to identify these women, but most are not symptomatic like you would have with the general population. And we actually have to test every single pregnant woman in pregnancy, symptomatic or not. We test everybody between 24 and 28 weeks of pregnancy to see if they have diabetes or not.
If my mom had gestational diabetes, would I be more likely to have it?
Not necessarily. It all depends on your personal risk factors, but not necessarily.
Okay, thank you. Now, you mentioned medications, so I'm going to bring in all of this wonderful knowledge that we have from Janelle and Mandy. Can you all talk about what medications are normally used during gestational diabetes?
Yep, I can start. So really the preferred medication is insulin. And the reason is when we talk about medications, one thing that we look at is whether the medication can be exposed to the baby, and then also if it has a risk for like birth defects and that kind of thing. So insulin is really one of the preferred medications, and there are some oral medications, it seems, that can be continued in pregnancy. I think there's probably a bit of a debate about it, but it seems like there's someone for some reason can't administer insulin or there's some issue, then they can take an oral medication as well. Now, not every, for example, you may know someone who's on other diabetes medications. So not every diabetes medication is appropriate while someone is pregnant. So we're very kind of specific about which medications you can use.
Okay. Mandy, would you like to talk about which oral medications are safe during pregnancy?
I'm sure. So typically, if a patient isn't able to take insulin for whatever reason, may it be cost or injection fear, things like that, two agents that we typically use are metformin or medications, or a medication called glyburide. These are typically, they're a little bit safer, but there isn't any long-term data to necessarily support use of these agents. But if need be, after insulin, your options would typically be metformin or glyburide.
So when you mentioned those medications as well as the insulin, the glyburide and the insulin seem like they could cause a little low blood sugars. Is that a big risk during pregnancy? Anyone can chime in. Let's talk about that.
Yes, so we struggle a lot with glyburide, and maybe that's why, in fact, the latest recommendation by the American Congress of Obstetricians and Gynecologists and also the Society for Maternal Fetal Medicine is that insulin is first line, then we can go to tablets, and metformin is second line, and then glyburide third. And I think one of the reasons why glyburide falls really short is hypoglycemia. It does cause rapid fall in blood sugar in women. However, as the pharmacist told us today, like some medications may work, better in some patients than others, but we cannot try to figure out what will be the best for our patients.
And I'm sorry, I tried not to use too many medical terms, and I said hypoglycemia. So can Janelle or Mandy, can you talk about what that actually is and what that looks like?
Yeah, so hypoglycemia is low blood sugar, and it can present differently in different individuals. So sometimes this may be shakiness, sweatiness, feeling faint. Some people have lethargy or feel super tired and fatigued. It presents differently in various different people. It's kind of individualized, but those would be some of the things that you would look for to indicate that your blood sugar is dropping or is too low.
And one thing to add to
go
that.
ahead. Sorry. Yes.
Yeah. So as your pregnancy progresses, you may require like different insulin requirements. So that number may fluctuate just depending on where you are in your pregnancy. And then after you deliver, then they would definitely change based on your insulin resistance changing after the placenta is delivered. So it can definitely vary. And that's why we want to make sure that you're checking your glucose levels to make sure that number is not dropping too low.
Hillary, can you talk about the diet, how diet plays a role in treating gestational diabetes and whether it's different if a patient is on medication or not on medication?
Yeah, so, back to those carbohydrates, we know they raise the blood sugar. And if someone were to be taking insulin, we do want to make sure that based on the number of carbohydrates they're eating, based on their insulin dose, that carbohydrate will be covered by what that insulin dose is. Because if you were to dose yourself with insulin after you had eaten some carbohydrates, if that weren't the right number, you may still end up with high blood sugar. Or if the insulin dose were too high, then you may end up with low blood sugar. So really working with your medical providers on figuring out how much insulin is dosed for your body to help regulate your blood sugars. You're keeping track of how many carbohydrates per meal and per snacks to make sure that blood sugar doesn't go too high or go too low.
Thank you very much. Is there any role for continuous glucose monitoring in gestational diabetes? Are those being used? Yeah.
Well, the insurance companies honestly would not cover these.
Okay, right.
I don't know. Maybe the pharmacists have a little bit more to say, but I actually just wore one myself a few months ago because I wanted to see how it felt, and because only my patients with type 1 diabetes have had the luxury of having continuous glucose monitors. But what we found out in the last year or so is that there are sprinkles here and there where some insurance companies will cover it, and patients are beginning to ask for it for them more and more. So these days I try to find out, I try to call the pharmacists at the hospital, actually at the outpatient pharmacy, and they're able to give me a little bit of insight when a patient asks for the continuous glucose monitors. They are very convenient, and the patients really love it. As for example, in pregnancy, they have to check their blood sugars 4 times a day. In the morning when they wake up before they eat or drink anything, and then 1 or 2 hours after each meal. So that's 4 times that they have to prick their fingers and write down these numbers every single day for months on end. So that can be a little bit tough for them. So yes, we are trying, but just a few of my patients have been able to get these and are able to use this during pregnancy, and it's just an insurance issue.
And I'm tying this in with our other conversations, and you mentioned type 1 diabetics. Do type 1 diabetics get to stay on their pumps when they are pregnant?
Correct. They do get to stay on their pumps. They have their continuous glucose monitoring system. Yes, all of that is, they get to stay on that during pregnancy.
Okay. And pharmacists, do you guys have any information about the continuous glucose monitors in pregnancy?
So I don't particularly work with continuous glucose monitors in kind of my practice, but I'm not sure if Mandy has any more insight about it.
Yeah, so previously, like the provider said, it does depend on your insurance a lot of times. Most insurances will require multiple daily injections, so taking mealtime insulin, 3 or 4 times a day. And there are some instances where you could just be on a once daily injection, and the insurance will cover it. But they want to make sure that you're having multiple injections and that you have a testing frequency that's going to require you to check 3 to 4 times a day. It is getting a little bit better as far as getting access to CGMs or continuous glucose monitors for patients who, may not necessarily be on multiple daily injections and things like that. But a lot of it is very dependent on who your insurer is and the documentation that your doctor puts in the note to make it a little bit easier for them to see if that documentation has to be sent, whether or not they can approve or deny it.
Okay. Thank you very much. So, Dr. Odibo, why is gestational diabetes considered high risk? What possible problems might occur if it's not treated appropriately during pregnancy?
Absolutely. Okay, so when we look at risks, we look at them in 2 ways. What are the risks to the mother herself for having gestational diabetes? And then what are the risks to the fetus? And let's start with the mom. Any mom who has gestational diabetes is at increased risk for a number of pregnancy complications, including preeclampsia, which is a severe form of high blood pressure that can happen in pregnancy and can cause babies to be delivered early. There is no cause for it. There is no cure for it. Delivery is the cure for preeclampsia. There is increased risk for C-section. In any mom who has gestational diabetes. There is also increased risk for type 2 diabetes later in life. And this is, I think, one of the most serious concerns that we have, because we have data to show that if women who have gestational diabetes do not take care of themselves, even outside of pregnancy, and we mean good diet, exercise consistently, that their chance of getting type 2 diabetes in the next 22 to 28 years after pregnancy is upwards of 70%. So we're talking about 7 out of every 10 women who have had gestational diabetes, who neglected to take care of themselves outside of pregnancy, will eventually develop type 2 diabetes. It's just a matter of time. And for some of our minority groups, especially the Hispanic groups, that time period is even shorter. It's 7 years. It's about 7 years. And I've seen this myself in our practice, where I took care of patients a few years ago that had gestational diabetes, and they come back for another pregnancy 2 or 3 years later, and they already have type 2 diabetes. Now, when we talk about the risk for the fetus, this is, of course, very troubling for us. When the baby continues to get steady stream of sugar, the same thing that happens in adults will happen in the baby. The baby starts growing really big. So these babies become really big. They are 8.5 pounds, 9 pounds, 10-pound babies, and it is difficult to deliver these babies. So during the process of delivery, it's not easy for them to come through the birth canal. It's not easy for them to deliver vaginally. We run into obstetric emergencies where the babies get stuck. It's called shoulder dystocia. Their head delivers, the rest of their body cannot deliver, and it's an emergency, and we can lose babies for that. So we actually have some weight cutoffs in obstetrics, where if a baby is measured to be at a certain weight towards the end of pregnancy, we go ahead and offer the mom a C-section. We do not even try to have these babies delivered vaginally. The other problems is when the baby is getting this whole stream of sugar coming in, the baby's body will produce insulin, which helps. So insulin is a chemical that helps to the body to kind of use up the sugar that it has. And the baby will have very high levels of insulin because he has very high levels of sugar. And after the baby is delivered and we cut the cord, we basically disconnect the baby from the mom, and the baby is no longer getting this steady stream of high levels of sugar, but the baby still has very high levels of insulin, and their blood sugar drops. So they have very low blood sugar. So these babies, after they are born, they end up in the NICU quite a bit, because now you have to give them sugar to get their sugar to be up because it's so low. They also have other problems like their, what we call electrolytes, like their sodium, their potassium. These are all chemicals in our body that are supposed to be in balance. They will become off balance, basically, because of excess sugar in the baby's body. And then there is increased risk for stillbirth. So we tend to lose these babies quite a bit. So we do recommend that they are delivered at a certain time. Like if you have gestational diabetes and you're on medication, you have to be delivered before your due date. If you're not on medication, we will take you up to 1 week after your due date, but that's it. We deliver you because there is increased risk to lose these babies. And then the increased risk for childhood and adult obesity. So these babies are at increased risk for not just having this problem go away after they are born, but they are also predisposed to having long-term issues later in life.
Well, you said a lot, so I have a couple of questions to follow up on a lot of the things that you said. First of all, when you have a patient who had gestational diabetes and then they come back and they have type 2 diabetes, what do you normally do? Do you leave them on metformin, or do you normally have to add insulin? And maybe the pharmacist can speak to this too. Which medications do they absolutely have to stop if they're on, if they have type 2 diabetes and they're taking other medications?
Yeah, so I can take first pass at this one. So oftentimes with gestational diabetes, there may be other chronic conditions that the patient may have as well. So medications like lisinopril or losartan that are used for blood pressure should be stopped. Certain cholesterol medications shouldn't be utilized in them either. And then medications that, such as like Jardiance, or basically medications that aren't the insulin and metformin, are kind of the first two options. And then everything else, I think you need to weigh risk versus benefit with your provider to see what they think would be best. But those would be the more preferred options, and then kind of just weighing the risk versus benefit with others. But definitely avoiding certain high or blood pressure medications, certain cholesterol medications. And then things like antidepressants, that's another thing that you can talk to with your provider. Some of those are safer than others. So it's really weighing risk versus benefit.
Thank you very much.
And I mentioned earlier that we get pregnancy questions all the time in my particular clinic. So I think, like, for example, in neurology, you see issues like, for example, someone might have a history of like seizures, for example. So, you know, again, the risk versus benefit, we don't want you to have a seizure while you're pregnant. So it may require a change to a different medication that's been demonstrated to have more safety information than others. And then in some areas, the neurologist might feel comfortable with kind of stopping a medication completely while you're pregnant. So yes, it does become a discussion as to what the benefit versus risk is, as Mandy was mentioning.
Imelda, can you speak to how you normally start treatment for a type 2 diabetic who comes into to see you during pregnancy?
Sure. So when they get diagnosed with type 2 diabetes, it depends on if they were diagnosed outside of pregnancy. If they have already been diagnosed and they are already on a medication, it depends on what they are on. Most patients are just on insulin, and it doesn't. So with the insulin, it's either like a longer acting insulin. Some of them, I don't see a lot of them on the short acting ones. So the ones that are on insulin are like on Levemir, they're on Lantus, they are on MPH, you know, kind of the longer acting insulins. And we usually keep those. We do not change those. They continue on those medications. What in pregnancy, what we do a lot, because we need to do a lot of fine tuning of their glycemic control. Most of them we will end up adding shorter acting insulin that they have to take with their meals. We have the Humalog, the Novolog, and the pharmacists are here to speak more about these, but we tend to add those with meals. The long acting ones they will take in the morning and in the evening, and then the shorter acting ones they will take with their meals. If they are already on metformin, we have them continue the metformin. As the pharmacist explained earlier, insulin doesn't cross the placenta, but metformin and glyburide do. We do not have very long-term studies, but what we do have is reassuring. We keep them on the metformin, and then we can add insulin to it. If they were only on metformin outside of pregnancy, we can add insulin later if we need to. We can max out. The only problem is that our max dose for metformin is 2,000 milligrams a day. So I see a lot of our patients where that doesn't do it for them, and we would have to max out on the metformin, which is, you know, use up to the highest dose, and then we would have to add insulin to it.
How often do you, this sounds intensive, so how often do you typically have to see these patients during their pregnancy?
For me, because I'm a high-risk OB doctor, I actually have contact with my patients who have any type of diabetes, type 1, type 2, gestational diabetes, once a week. They have to email me their log once a week. They monitor their sugars 4 times a day. This is like a camp here. This is like a military camp in my clinic. And they email me their log every single week. On a Wednesday, everybody knows they have to, when they wake up in the morning, they email their log, and we are in contact. That way I adjust their medications. We talk about diets, you know, did you see your nutritionist? You know, did you touch base again? Can you see what's going on for dinner? So we do that. And then the ones that are really very, that need very close monitoring, and I actually see them face to face like every couple of weeks, but those who are stable, well controlled, I see them once a month.
Are you their only OBGYN? Do you deliver their babies, or do they have another doctor?
Yes, they have primary OBGYNs. I am just their high risk, helping to take care of them. So they do see their primary OBs, but when I'm managing the patient, I solely take care of the patient. except patients who have type 1 diabetes, because they are on a pump, they have their continuous glucose monitors, and they usually also have an endocrinologist who is helping with their care.
Is it safe for type 1 diabetes to become pregnant? And when they're making that decision, is there any way that they can speak to Hillary or you? And is there any advice that you normally give them?
Yes, it is safe for them to become pregnant. However, we advise that they achieve a certain level of control before attempting pregnancy. So we want your hemoglobin A1C, which is a blood work that kind of tells us what your body is doing over a 3-month period, how your body has been managing sugars. We want that to be less than 7 before you start attempting to be pregnant. So ideally, we want to see these patients for what we call preconception counseling, which is a visit with a doctor before you even start attempting pregnancy. And at that visit, we'll talk about the goals, we'll talk about the importance of having good control before you become pregnant, because having poor control at the time of pregnancy can increase the risk of congenital malformations like heart abnormalities, spina bifida, like openings in the spine, abnormal brain formation. So we talk about all of that, and then we make them go see Hillary prior to even attempting to get pregnant, to make sure that they start eating right, they start, controlling everything before pregnancy.
And Hillary, what do you tell them? Oh, you're muted.
Sorry, my bad.
That's okay.
So what we really look at is, since most type 1 diabetics do have that CGM, looking at their blood sugar levels before meals and after meals, their fasting blood sugar and before bedtime, and making sure that the food that we're eating is helping to control or adjust those blood sugar levels. So we're really looking at daily fiber intake, daily protein intake, the right amount of carbohydrates too, and even looking at types of carbohydrates can be helpful. Looking at complex carbohydrates versus simple carbohydrates that break down and raise blood sugar more quickly than those complex. And then looking to, if they are using a pump, looking at that dosing of insulin to that carbohydrate amount to make sure we're not too high or too low, and kind of pooling all of those factors together to make sure that that is that healthy diet. And we're looking at increased nutrient needs for pregnancy and looking to see if we need to add anything extra to help support fertility and growth for baby.
Do you do the same for type 2 diabetics? Do they also need to come in for a pre-pregnancy or preconception consultation? Okay. Is there any more difficulty getting pregnant when you have type 1 or type 2 diabetes?
They may not necessarily have difficulty getting pregnant from our experience, but they may be predisposed to miscarriages more often if they are not well controlled. So recurrent loss is a sign of poor control prior to pregnancy.
Is there any, if you had to rank gestational diabetes versus type 1 and type 2, are either one of those a higher risk during pregnancy, or are they just about equal?
If I were to rank, I would definitely rank type 1 and type 2 diabetes much higher than gestational diabetes. Because as Mandy mentioned earlier, the ones who have type 1 and type 2, they already have some other medical issues. They have end organ damage, they have some cardiovascular issues, they may have cholesterol issues, especially with type 2 diabetes. They may have hypertension already. So I would rank those ones at a higher level of acute, more complications than would be expected with gestational diabetes.
And the other thing that you mentioned during your previous statement was that you said something about having a big baby. So if I had an 11-pound baby and I was not diagnosed with diabetes, does that put me at risk for having gestational diabetes next time?
As a high-risk OB doctor, sometimes I really question whether you didn't really have diabetes or not that pregnancy. And I have patients all the time, they had a baby who was 10 pounds, 10 and a half pounds. And I go, well, were you diagnosed with diabetes that pregnancy? They say, nope. The reason why I doubt that very much is because they test, and I know we didn't talk about it, but let me touch upon that a little bit. The test that we use to diagnose gestational diabetes is not a perfect test. It can miss quite a number of women. So for those who are not aware, we give you at between 24 and 28 weeks, we give you this sweet drink. It's like Fanta. Like I grew up in Nigeria, so we drank Fanta all the time, and it's so sweet.
It's
so
not very
good.
tasty either.
Exactly. But it has a lot of sugar in it. We start with what we call a 1-hour test, where we give you a 50-gram load of sugar in that drink, and you drink it, and then you sit for like an hour and we measure your blood sugar level. So that's what we do. What we're doing is we're challenging your body by flooding your body with a lot of sugar at the same time to see how your body will handle that sugar. If you fail, and we have certain cutoffs, if you fail that test, that 1-hour test, then we bring you back. Sometimes we do a 2-hour test where we will now give you a 75-gram load of sugar, or we bring you back for a 3-hour test, which will give you a 100-gram load of sugar. So we're giving you more sugar to challenge your body even more. Unfortunately, this test can miss quite a number of people who actually have diabetes. So what I do in my practice is, even if you passed your glucose test, if your baby starts growing really big, 2 weeks ahead, 3 weeks ahead of where we project where the baby would be, I would make you literally check your sugars at home. I will make you prick your fingers at home so that I can have a better understanding of what your body is doing on a daily basis. But regardless, yes, we do have some people out there who just grow big babies. It's constitutional. They just have big babies. So yes, there are some people out there who are totally gonna have a 10-pound baby.
So Mandy and Janelle, both of you, I think, are clinical pharmacists. So what is your one-on-one contact with gestational diabetes, or do you just mainly help the physicians to manage gestational diabetes patients, or do you actually meet with them?
So at my specific clinic, we actually have an endocrinologist that works with the patients who have gestational diabetes. But I may get looped in to call patients, and that could be on a various different cadences, like every 2 weeks or every 4 weeks, or a little bit tighter if needed. We can communicate either via telephone, via MyChart, or if you have a portal where you can communicate back and forth with your provider. So it really just varies based on what our endocrinologist thinks is the monitoring needs to be. But again, it's usually, I'll call or MyChart them every 2 to 4 weeks and get their logs, and then I'll review it and also review it with their endocrinologist, and then collectively we come up with a plan on what adjustments need to be made.
Thank you. Janelle?
Yep. So I don't particularly do diabetes monitoring in my clinic. We do get a lot, like I mentioned, a lot of questions about whether medications are appropriate. They're neurology medications in pregnancy. Our Duke has a pharmacist in the endocrine clinic who does that monitoring. So she would probably, be the one to follow up, and she has follow-up visits similar to Mandy, where she's monitoring kind of glucose levels and following up with patients from there.
And what glucose levels are too high?
So in pregnancy,
Yeah.
I can take this one. Either I or Hillary can take this one. So in pregnancy, in the morning, when a patient wakes up before eating or drinking, we call it a fasting value. We need that to be less than 95. So normal would be less than 95. And if the patient is checking 2 hours after a meal, the number should be less than 120. Some people check 1 hour after a meal, and that's fine. And people would use any cutoff between 130 and 140 for that, for 1 hour. I don't know if Hillary has some other
And
recommendation.
Hillary, what if my meal was like pasta and breadsticks?
Yeah, so if your meal was pasta and breadsticks, pending the portion, now if you just had like a bite of each, probably no big deal there. But if you had what we would typically eat, you know, like a bowl full and a couple breadsticks, that blood sugar is going to skyrocket because pasta and breadsticks don't have any protein or fiber to them. So, you know, paring that meal down where maybe it was about a fistful of pasta with 3 or 4 meatballs, and then we had like a side salad, and we did a small piece of garlic bread, that would really help control that blood sugar level so we don't see that skyrocketing blood sugar.
Thank you. Thank you. Is there any food that we should absolutely avoid during pregnancy, for gestational diabetes? I know there are lots of foods to avoid during pregnancy, but for gestational diabetes.
Yeah, that's a great question. Unless you are allergic to a food, or it falls in that category of safety issue for pregnancy. With gestational diabetes, we can include all foods. We just have to look at that carbohydrate content and how it fits into the day. In pairing too, so if someone were to have a dessert, I typically say don't have a dessert by itself. Have that as part of a meal or pair it with another protein source so that we can help mitigate and counteract what that sugar level would have on the body, and keeping it in a mindful amount, you know, probably not 3 times a day every day, but a couple times here and there should still be able to fit into a diet that would be that would work well for gestational diabetes.
And what if I'm vegetarian or vegan? So how do I come up with enough protein to counter the carbs that I might be eating?
Yeah, that's another really good question. So when we look at plant-based eating, whether it's vegan or vegetarian or even flexitarian, we want to look at what are kind of our protein sources. For plant-based eating, we have protein sources that have starches. We have plant-based sources that are more along the lines of fat and protein paired together, or ones that have low carb like tofu or seitan. Those are higher protein with lower carb amounts. So really understanding the carb amount in the protein source you're using and using multiple sources. So generally in vegan and vegetarian eating, we're not going to have, you know, one item that has like 20 or 30 grams of protein, but maybe it's a stir fry where you use brown rice, which has a little bit of protein, broccoli, which has protein in it. You use some tofu that has protein in it. And then you have some cashews on top too, that are also going to provide protein. And we manage the carb amount by using multiple sources.
Very interesting. Thank you.
Mm-hmm.
So this is the time at the end. Well, you guys have been wonderful. Thank you very much. Where I ask people to leave the community with one bullet point to think about when they're dealing with gestational diabetes or ways to prevent gestational diabetes. And we'll start with Mandy.
Yeah, I think it's really important that to realize that your lifestyle may change in the interim, but not to let like gestational diabetes is a part of your lifestyle. It doesn't run your life. Like, don't let it change you specifically to bring you down. It's something that you can control and kind of modify to make sure you and your baby are safe.
Thank you. Janelle.
Yeah, so I would probably say that to know kind of what resources you have around you. You see Mandy's in a clinic, I'm in a clinic, and we have pharmacists that are now kind of embedded in these areas. So I think kind of knowing what people can help you and answer your questions would be great. And kind of asking your provider about kind of what additional resources that are available to you would be helpful in helping managing your gestational diabetes. So I think that would be good to take home.
Thank you. Very good. Hillary?
Yeah, I always think it's important. Don't beat yourself up on what caused the gestational diabetes, but what can you do now at this point with lifestyle and eating and exercise, medication if needed, and working with your provider so that you can have this happy and healthy pregnancy and kind of thrive from there.
Thank you. Dr. Odibo?
So this is just when I have to remind everyone how wonderful a job I have to take care of pregnant women every single day of my life. These are women who are very motivated. They are amazing. They will do anything for their babies. So when I ask them to stick their fingers 4 times a day, for 7 or 8 months of their pregnancy, they do exactly that. So I just want to continue to encourage them to be the great mothers that they are, to continue to take good care of themselves during the pregnancy, and even more importantly, after the pregnancy, because they do such a good job. They amaze me every day by the level of dedication and the hard work that they put into having a wonderful and successful pregnancy.
Thank you very much. Actually, we have a couple more minutes. I wanted to add one more thing, and that was to talk about exercise. Does exercise play a role in gestational diabetes?
I guess Mandy can go first. Hillary can go first, I guess, and then I'll go.
Yeah. So I kind of like to think of exercise like if we have a house, the front door is how we can use food to monitor our blood sugar levels. And I kind of like thinking of exercise as the back door because it's this sneaky way, because when we are active, it uses up the sugar in our body and helps to lower our blood sugar levels. So it's that sneaky way that we can use exercise in working with our bodies and how they work with our blood sugar levels to help manage it and play a part there.
Thank you.
Absolutely. We encourage our patients. In fact, once we send them off to Hillary, we come up with an exercise plan. We encourage our patients to exercise for at least 30 minutes, at least 5 days a week. And I tell them you don't have to go register at a gym, because I did that and it never worked. I never went to the gym and I wasted all my money. You don't have to go to the gym. You don't have to do anything fancy. You just need to take a walk in the evening with your other little kids, take them to the park, run around, take a walk with your husband, your partner, your mom. If you can just do that, and maybe walk at a little bit of a faster pace to increase your heart rate, that would do 30 minutes, 5 days a week. So that is definitely part of their regimen. Some of them use it like after dinner. They go walking and they always tell me how good their postprandials, their blood sugar, when they check it after dinner, how good it looks, because that exercise helps, of course, to help the body to use up that sugar that they've just consumed. So yes, it is a very integral part, whether you're on medication, whether you're just diet controlled, it is a very important part of the management of gestational diabetes.
Okay. Well, I hope that everyone has learned something today about gestational diabetes. I certainly have. I'm a family medicine physician, but I always learn things from these conversations. But the thing that I would like to leave with everyone is that when you get pregnant, you're really not eating for two, and that you have to monitor what you're eating and remember those suggested weight gains for everyone when you are pregnant. So once again, this is Dr. Lakeisha Jarrett, and this is the YWCA's Talk on Health. And we will see you guys next month.